Hello, my name is Cole Ashton, and this video serves as my Module 5 Safety Reflection for Professional Health and Nursing Concepts 2. This clinical experience took place on February 9th, 2026. The patient was a 61-year-old female admitted to the Progressive Care Unit for a diagnosis of acute diastolic heart failure. The patient had a past medical history of type 2 diabetes, hypertension, coronary artery disease, hyperlipidemia, COPD, chronic kidney disease, peripheral artery disease, and was septic upon admission. The provider elected to order a basic CMP, CBC, electrolytes, and routine lab work. A novice nurse at the time, this took place at about 04:45 a.m. before we arrived on the unit, received the lab results. The RN reviewed the lab work and determined that the patient was anemic. The RN incorrectly interpreted the hemoglobin A1C, which was 5.7, as hemoglobin. So at 0500, the RN placed a call to the physician, whom was at home and off-site, for an order for a blood transfusion due to a hemoglobin of 5.7. The actual hemoglobin at that time was 10.9. Based on this information, the physician ordered 1 unit of whole blood to be infused, and independent double verification took place with another RN on the floor as per protocol. The patient received the blood via PIV and began to have a reaction there soonly after. The patient became tachypnic, febrile, and malaised. The blood was stopped immediately by another RN who was walking by in the room. Upon review of the lab work, it was determined and reported that the novice nurse had inadvertently reported the blood hemoglobin as low, misreading the hemoglobin A1C as hemoglobin itself. A note was placed by the provider on the patient's chart that the bedside RN misinterpreted lab studies and confused A1C with hemoglobin, administered 1 unit blood unnecessarily. Patient is in good spirits. So the HCP was notified that the mistake was discovered shortly after at about 0530. The patient remained stable following discontinuation of the blood and administration of diphenhydramine IV. In regards to orders, there were new orders. There were orders to reassess vitals frequently. A new CBC, CMP, and a hematocrit order was also placed. We don't, at this time, based on my review, this was still fresh on the unit, so it wasn't widely discussed at this point in time, but it was happening to the patient I was caring for. It's unclear if the family or patient themselves were notified. I did take note that the patient had a significant language barrier and only spoke minimal English, like yes, no, okay, ice were about the 4 main words that she knew in English. And there was no documentation of use of an interpreter for the past 48 hours for this patient. With my own experience, and I don't know if this is accurate for the overnight care or when the blood was administered, I will note that the interpreter iPad was 100% dead and had to be charged before I used it for this patient. And I believe this also constitutes another healthcare error of failure to document and or failure to communicate with the patient. No education was documented as being provided to the patient, so legally speaking, no education was provided. The patient was experiencing an acute allergic response to the blood received via the transfusion. So this is the assessment findings after the error. The patient was tachypnic, febrile, and ill-appearing. With the diastolic heart failure, we were very concerned about fluid overload on the heart, so we were frequently assessing lung sounds as well for this patient. Again, as stated, the lab work hemoglobin was 10.9, hemoglobin A1C was 5.7. The results remained stable after administration of the blood despite the reaction. The continued assessment, we continued monitoring blood pressure, temperature, level of consciousness, heart rate, respiratory rate, lung sounds, renal values, bilirubin, hemoglobin, hematocrit, A1C, CBC, CMP, which were all routinely monitored anyway. We just kept going. This patient was actually supposed to be discharged the night of following into the early day tomorrow when the transfusion was initiated, so unfortunately she did have to stay another day on the unit. We ensured the follow-up plan of care is ensure patient safety and tolerance of transfusion, discharge when patient was deemed stable. So based on this experience, I learned how dangerous nursing actions can be. So not only is the RN who instilled the blood at risk, but so is the nurse who independently double verified the blood because the values did not reflect a need for transfusion. This has definitely changed how diligent I will be when double verifying medication, and I will be confident and educated on my ability to interpret lab work for patients. Not interpret, well, yeah, interpret and send it off to the provider. I need to be confident, so that will definitely encourage me to review all of my my lab values and ensure my understanding. In regards to the EHR, I believe it did both. I think it helped and it hurt. The EHR was responsible for displaying the results to the RN. I wouldn't blame the EHR 100% on the display because hemoglobin A1C shows up under chemistry, so I'm not sure how she reviewed that as a hematology result, but I guess it was reviewed as hematology. But in caveat to that, the EHR also alerted the other nurses to what had occurred when it was reviewed properly. So in the pre-error, the nurse should have reviewed the lab work correctly and recognized that a drop in hemoglobin from 10.9 to 5.7 in a matter of hours with an asymptomatic patient would be considered extremely and highly unusual and should have prompted immediate suspicion. To fall from 10.9 to 5.7 with no symptoms or active hemorrhage is significant. I would definitely expect there to be symptoms. Furthermore, the nurse who independently double verified the infusion should have also reviewed the lab work before signing off on the transfusion to make sure that it was warranted, I believe. And I also think that the physician is partly responsible. I know that that's taboo in the medical field, but the physician ordered lab work, not lab work, ordered blood for a patient with a suspected hemoglobin of 5.7 and didn't recognize that there were no symptoms for anemia, especially at 5.7, from a previous result of 10.9. And I also believe that the physician was unprofessional with their report on the EHR. I think that the note that they put on the patient's chart that subjectively stating what happened without objective fact or witnessing it was extremely unprofessional and can lead to liability for both the hospital and the nurse and the provider themselves. With an asymptomatic patient with no bleeding, I don't know why the physician or the nurse would deem that appropriate, but I guess they did. The error was handled appropriately except for not being documented and reported to the patient, so it was handled, I guess, as well as it could have been at that point in time. What could each team member have done differently? Reviewed the lab work. I think that that would have, slowing down before you administer a high alert medication, such as blood, should definitely have occurred. The nurse who independently double verified the blood should also have reviewed the lab work, I believe. The physician should have noticed that there were no symptoms of anemia from a previous hemoglobin of 10.9 to 5.7, and that the patient was in good spirits and fine and sleeping with no active hemorrhage should have been a red flag, and it should have been a red flag to the nurse as well. Ultimately, it does fall on the registered nurse who inappropriately displayed the lab work and subsequently delivered the blood. She was the final one in the chain to deliver the blood, so not only did she incorrectly administer it, but she made a medication error by administering it for an unneeded reason. And the healthcare team members involved were the primary bedside nurse, the RN who double verified, and the physician. Overall, it was a very unfortunate scenario, especially for a patient newly diagnosed with diastolic heart failure to instill blood unnecessarily when she had a normal hemoglobin, especially somebody with kidney disease. I mean, there's all kinds of fluid pathophysiology issues with this patient, and to unnecessarily transfuse an entire unit of blood is really, really unfortunate, I think, for a lack of better term. So it will definitely change how diligent I am with reviewing lab work, ensure my understanding before I review something, and definitely slowing down before administering a medication that's high alert. It's shocking to me that 3 healthcare professionals on the same unit, with each with a different protocol, allowed this to happen. I think with all the steps in place, it should definitely decrease the occurrence of this, but it's just so, I don't know. It's very unfortunate, and it definitely will teach me to slow down and to pay attention.